anesthetist in Obesity in Sweden. And we are specialized only to take care of the obese patients, and we get to meet them both pre, per, and post-operative. And it's a common feeling among the staff that many patients suffer with post-operative nausea and vomiting pump. And that is why me and my colleague felt that studying this matter could be interesting. Nausea is common after general anesthesia, and when you perform a laparoscopic surgery with insufflation of carbon monoxide, it is known to increase pulp. Corticosteroids has been shown to be effective when given parenterally. In our clinic, all patients were given 8 milligrams IV from the standard protocol. An oral administration was not yet tested. That is why we wanted to test one single dose given orally. No comparative study has been published. 94 patients were randomized in the study to provide us this data. After getting approval of the ethics committee in Sweden, we decided to do 2 separate studies randomized. In the first study, patients were orally given 8 milligram betamethasone versus placebo. And in the second study, we gave patients 8 milligrams betamethasone orally or intravenously. Both studies were performed as double-blind, randomized studies. All patients were signed up for elective laparoscopic gastric bypass. All doses were given preoperatively by a nurse at our ward, and we were using 100mm visual analog scales for measuring pain, nausea, and tiredness. All results were put to the protocol, and the measurements was made at baseline and when the patients arrived at the recovery room, and then at furthermore 5 times in the first 24 hours. We collected information on demographics and risk factors. Questions were given about smoking, previous anesthesia, and motion sickness. These are all well-known factors which can increase PONV. All patients were subjected to the same technique, and we used a propofol and fentanyl in a target control infusion. And from a standard protocol, the weight is set as the height minus 100. And we give 1 dose of atracurium, 16 to 20 milligrams for relaxation, and ketobemidone, 10 milligrams for women and 50 milligrams for men. And we have 1 intravenous catheter. We use tracheal tube number 6 for women and 7 for men. And all patients are intubated with, we use the CMAC, the video laryngoscope. Gastric tube we use is Cherrier 32, and we put the marking at 30 centimeters. And when the pouch is tested, we use 50 milliliters sodium chloride and methylene blue. All supplementary post-operative medications, such as antiemetics and analgesics, were noted at the protocol. And the gender distribution was 80% women in our study. And the age was 44 years, plus minus 13, and the BMI 38.5, plus minus 5.2. And there were no differences in risk factors for PONV, post-operative pain, or in need of supplementary medication. And this is the results of the first study, and it shows the patient's measurements on the visual analog scale regarding nausea. And the patients not given oral betamethasone is the control group, and they peaked at 7 o'clock in the evening, and the difference you can see is significant. And in the second study, the results were at no point any significance. So some comments. We have a short operative time, 25 to 45 minutes in average, so the patients are not given a lot of anesthetic drugs. All surgeons use the same standardized technique. We have an automatic procedure, no blood transfusion. All patients start oral intake a few hours post-operatively. There are no remaining catheters. The stay at the recovery room is 2 hours, and then the patients are up walking. All patients are discharged at the day after surgery. We think our model may be representative. And for conclusion, We know that corticosteroids are effective, and we also know that oral administration is as effective as given intravenously.